Welcome to this special Crown Council webinar. This is Steve Anderson. We're delighted to have Dr. Jim Pasternak with us today, along with Pam Peterson from the Total Patient Service Institute, to talk about saving lives, one oral cancer exam at a time. Dr. Jim Pasternak has been a lifetime qualified member of the Crown Council from Chatsworth, California, part of LA. He's been in practice for over 37 years. Jim's been a great contributor to the Crown Council over the years and has become an expert in the area of oral cancer exams. Jim actually does this presentation for DenMat, who has obviously a vested interest in many of the technologies that we'll talk about today, but Jim is receiving no compensation for his presentation today on their behalf. So with that, the format of our today's presentation, Jim's going to walk through technology and science for the first 30 minutes or so of our webinar, and then Pam Peterson and I will continue with verbal skills and how to present this technology to your patients. So with that, Jim, welcome, and thanks for sharing with us today.
It's my pleasure, Steve. Thank you very much. Welcome to today's seminar on enhanced oral assessment. This is my contact information, and I encourage you, and you're welcome to, of course, to contact me if you have any further questions after today's webinar. My official disclaimer. Okay, so let's talk about what we're going to be doing today. We're going to be learning about the actual nuts and bolts of the enhanced oral assessment, how easy it will be to add it to your practice, how you can hit the ground running, and the verbal skills in order to introduce this into your practice. We're going to talk about the current public perception, the facts of oral cancer, what you're doing currently, adding to this oral cancer screening with the enhanced screening, and how to implement this into your practice. Okay, a lot of people in the news these days. Michael Douglas has stage 4 throat cancer. Jim Kelly, former quarterback, has been diagnosed. Just recently, Tony Gwynn passed away, a great loss. I'm sure we're all familiar with Aaron Spelling. This came out, California Dental Association, hot off the presses, and as I mentioned, it's a terrible loss, and we really need to educate the public and get them on board. Whole host of other people that, dead or alive, have had oral cancer, and some have succumbed to it. Okay, so this is almost 8,000 people a year that are dying of oral cancer, and one of the easiest preventable oral cancers that is in existence. Okay, currently with the way we diagnose now with visible light exams, the survival rate is only 52%. But when we diagnose it early, we can tip the odds in favor of the patient, and we can get to around 80 or 90%. It's this late diagnosis, even with the thorough exam, that leads to a high death rate. So let's talk about a few items here. On your visual cancer exam, have you ever found something suspicious? Why should you consider adding an adjunctive device now? What if you don't really know what you're looking at with that adjunctive device? What will this whole process entail? And should you or not charge for it, and what should you charge? Okay, so as we're talking about, if the visual exam is enough, are you offering enough to your patients? Are you using one of the technologies like either Visalite or Bellscope in your practice now? All manufacturers do offer training, and usually online, and a wealth of information is usually given with a notebook with photos. And then, of course, whether or not you want to charge for this service is something we will talk about, and that's your choice. Okay. I published an article a couple months ago, and The sidebar says it's a dirty little secret, and it is, that less than 20% of all practicing dentists actually perform a visual light oral cancer screening. I am confident that present companies accept it since we're a high-end group of practicing dentists, but less than 2% of practicing dentists use any sort of adjunctive device. And I know we can do better than that. This is why I've become an evangelist for thorough oral cancer screening. Okay, how will you actually implement this into your practice? What should your protocol be? And how will you introduce this new service? Okay, this should be the message to your team. Everyone plays their part. Everyone, front desk, hygienists, assistants, and of course the dentist needs to be on board and be knowledgeable. As Steve mentioned, we are going to be providing scripts, and TOPS Institute is going to be speaking to that today on how to introduce this into your practice with the right verbal skills. Okay, so the nuts and bolts. With visible light, you're going to do a thorough extraoral and intraoral head and neck exam, and we're going to walk through this right now. I presume most of you this is old news, but for some of you this may be new. Also, you absolutely must have magnification in order to do your visible light exam. The Velscope has magnification built into it. Okay, flat borders of the tongue. Looking down the throat at the tonsillar pillars, the pharynx, looking in the vestibules all the way around, top and bottom, cheeks, buccal mucosa, hard palate, bimanual palpation to look for nodules in the floor of the mouth, and check extraorally the lymph nodes on either side of the neck. It's critical to do this in an organized manner so you don't miss anything. And when you're doing the visible light exam, you're also looking for certain landmarks that will help you to interpret the adjunctive device showings. Then you will do the adjunctive device exam. This shows the Velscope. The portion over here on the left of the Velscope is where you would look through. A safe blue light is projected into the tissues, and I will go into this a little bit more, and you will actually see a whole different picture that you've never seen before. Okay, it's also important to document your findings. You can get a camera included with the scope that locks onto the Velscope for documentation, and I'm aware of very few softwares that don't have an ability to store your photos, so that's really crucial. Okay, why are we here today, and what should we be doing for our patients? The take-home lesson in all of this is to find things sooner than later. As I alluded to earlier, the survival rate is greatly enhanced if you look at this with an adjunctive device and can detect things in stage 1 or 2 rather than at stage 3 and 4 when the tumors have invaded the basement membrane and have the potential for metastasis. Just to make it a little bit clearer, the stages, the bottom line is, why would you want to wait and diagnose things at a late point? So clearly you want to get to these things sooner than later. Okay, a little bit of science. Please don't glaze over, but this is actually pretty simple. So you have the tissue. Over on the right side is a diagram of your eye. Okay, so first the light is shined, which is I believe at about 550 nanometers, a safe blue light. So the light is actually not causing any harm. It's non-invasive. Okay, so the specific blue light is shined onto the tissues, and you get a reflection off of the tissues. Then some of that is absorbed, and then you get a fluorescence. The science behind this is incredibly simple. It took the National Health Department of Canada $46 million of research to figure this out. It was originally for detecting both lung cancer and cervical cancer, and it applies equally well to the mucosal tissues in the mouth, in the oral cavity. So the whole deal is that every cell in the body uses a process called the Krebs cycle to create energy from the food that we consume. And one of the byproducts of the Krebs cycle is something called FAD, and that fluoresces under a specific wavelength, which happens to be 550 nanometers. So next, you have a filter that'll filter out the reflected light, and it allows the fluorescence to show through. You ask, what does this really mean? Okay, I'm going to jump back here for half a second. The healthy tissue produces the FAD and therefore fluoresces. The pre-malignant or malignant tissues do not fluoresce and show up as a black area. There are a few other things that can cause a false positive, which we'll talk about later on. But basically, this is the whole science. Okay? It has been recommended that all patients that are 16 years or older would have the enhanced annual oral soft tissue exam, simply because human papillovirus is on the rise. Plus, we have tobacco users, heavy alcohol users, and patients with a prior history of cancer, and they should have their exams every 6 months. It's of interest to note that the HPV virus is what's implicated, according to Michael Douglas, in his stage 4 throat cancer. Okay, so as I mentioned before, there are two key components to this exam. We have the conventional white light with magnification exam and palpation, and this is what the less than 20% of dentists are doing. It's a good start, and then do the Bell-scope exam. The reason why I recommend for patients 16 and over is because a lot of teenagers are sexually active and could get the HPV virus. Okay. As I mentioned, we talked about HPV, and it is basically a cancer of the cervix, but it has become more prevalent in the oral cavity. And this same virus can actually cause oral cancer. So we must screen every patient. 3 women die from oral cancer than from cervical cancer. It's amazing to me how many women I talk to actually turn down the screening. Even when I mention this, they kind of look at me blankly and say, so. But, you know, you can only do so much. We'll talk about verbal skills and try to be as persuasive as possible. Also important to know that 33% of all oral cancers occur in individuals that have no apparent risk factors. Again, you're going to have patients saying, but I don't drink and I don't smoke. Why do I need to worry about that? And this is where verbal skills come in to address that issue. Okay. We're talking about the fluorescence again, and this actually allows you to see these lesions much earlier than you could with this visible light. So then that leaves the question, why wouldn't you want to do this, and why leave it to chance? Also, it's key to understand that this is an early screening that has no differential diagnosis. So this is not a diagnostic procedure, merely a screening. And in most states, you can delegate this to your hygienist. Okay, then the next question is, how do you interpret what you see, and what training is required? The training actually is quite simple, and it'll make more sense in a minute. Okay, what you're looking at here is a picture under the scope, and as I mentioned, you can actually get some false positives if you don't know what you're looking at. That bright orange spot is part of the tonsils, and there's probably a pustule in there, and that happens to glow orange, so that's nothing to worry about. You see a lot of capillaries, and also when you have a lot of blood flow, that will show as a dark area. So it's important when you do the visual cancer exam to look and be aware of these landmarks. Okay, so this is completely normal, both with visible light and under the scope. Okay. Looking with visible light, you can see on the tonsillar pillars that there are blood vessels, and there's some darker areas. You can see this blood vessel on the soft palate and the pharynx quite clearly. And if you look at where it's scoped, it's pretty much the same thing. Even though some areas look a little bit darker, that's typically nothing to worry about. In the retromolar area, you can see like what looks like maybe a scar from a wisdom tooth extraction, and maybe a slight filmy white look. Take a look under the scope. It's pretty dramatic. And this is something you would not see with the naked eye. But you can see there's a huge black area where there's no fluorescence showing, and this, while not diagnostic, is pretty telling, and this I would definitely consider doing a biopsy on. This one was biopsy and turned out to be carcinoma in situ, so it's a good thing for the patient that they were scoped. Okay, here's another one. This male presented with kind of a funny feeling, like just a not quite right feeling on the hard palate. It was scoped. There are two fairly discrete dark areas. There's one on the upper left corner of the dark area, which is kind of round, and there's another larger patch. Okay, this one actually was a patient of mine, and absolutely no risk factors. He had no symptoms. This is what it looks like with visible light. There's like a slightly reddened area at the tip of his tongue, but he reported that that was traumatic injury, that he had bitten his tongue several days before. We scoped him, as we routinely do, and it's not pretty. This was biopsied, and tragically, the diagnosis came back squamous cell carcinoma. He had a pretty wide margin of his tongue removed. He is regaining the ability to speak, but thank God we found that before it harmed the rest of his body. Okay, the take-home lesson on these four pictures are sometimes you can see something visible, and it does turn out to be positive on the screening. Sometimes you can see something visible and there's nothing there, and it's a negative. So that's what you need to be aware of. Everyone needs to be screened to be really sure. You can't tell just from the visible light. They need to have the adjunctive device. Okay, on the buccal mucosa, you get these areas where there are bite marks from the cheek, and sometimes you'll have a calloused area, and these can show up as a darker area. That's not quite as dramatically dark as previous slides, but you want to make sure you're interpreting what you see properly. Okay, so the whole point is that you have to learn how to interpret, much like you would with x-rays. So, things don't jump out with a big C for caries on it, or T for tumor on an x-ray. It's the same thing. You have to know what you're looking at with the visible light exam in conjunction with the Bell scope. So it's a matter of interpretation and judgment. Whenever one of my hygienists finds something of concern, they bring me over and I will rescope it and then make the decision if we're going to biopsy or not. Burning question everyone always wants to know. You might want to jot this down. There is a code that can be billed to insurances. Frequently, our patients will ask if there is a charge and if their insurance company will pay for it. And part of your verbal skills are to address that objection. And simply we say that more than likely your insurance company will not cover it, but we will bill it, and if you do get reimbursed, it's a bonus. As we do bill it, more and more insurance companies are becoming aware of it, and hopefully at some point they will cover it. Now, from a financial point of view, if you don't get reimbursement from the insurance company and you still get the $20 to $25 per exam that most dentists are doing, with 4 exams a day, figuring 4 days of hygiene, your return on investment will only take about 6 to 8 weeks. Then after that, it's paid for. Or you can just tack on another $5 to $10 onto your exam fee if you decide you want to do it that way, and then include this exam for everyone. You talk about marketing so you can introduce to your practice and to the community, which could be potentially new patients. So you can send a letter or email out if you have the capability to do an email blast, which most of us do now. You can send that out. You might want to put a color graphic to catch their eyes. You can do a 1-day free oral health assessment clinic, and this can attract new patients if you get the word out in the community. I actually did a oral health assessment for the local firefighters because obviously they're exposed to a lot of things that we normally aren't that can cause cancer in general and oral cancer specifically. Talk to your patients, hand out brochures to your patients. Most of the manufacturers do have brochures that are available to hand out to your patients. I would send letters or speak directly to the physicians and oral surgeons in your area. And on that topic, your oral surgeon that you refer to really needs to have one of these scopes too, for 2 reasons. One is to see what you're seeing. Even if you send them a photo, they may have difficulty visualizing or understanding what you're seeing. And the other reason is to determine the margins of the lesion when they excise it. You may want to consider taking your oral surgeon to lunch and explaining to them what you're doing and get them enrolled in this whole program. Okay? And then the other thing is to ask your current patients for referrals, and this could be a good way to get those referrals when they see that you care about their oral health. So there are a lot of opportunities to create awareness. Okay, so in summary, we're supporting what we believe in, which is preventative health care. That's what we're all about. As I'm fond of saying, if you're the average Joe dentist, if you see a hole, you fill it. If you see a tooth missing, you replace it. And we should be doing more than that. You know, if we see crooked teeth, then we want to straighten them. Those are all important things, but there's far more to total patient care. Help preserve their quality of life. We find things early enough, then we're not going to have to subject our patients to disfiguring surgeries. This will help us to make improved and more appropriate clinical decisions on whether to biopsy or not. This will also help build our dental practices by getting the word out there, and we can also get more referrals. And you just may save a life. This is absolutely a win-win for both the patients and the practice. We are saving lives. We're on the front lines. I remember several years ago that we did beta testing for Visalite. We went to the Cactus League during spring training, and we did hundreds of oral screenings using both the visible light and the Visalite system. And we did find a lot of oral cancers on the baseball players. and a lot of them were using, and still are unfortunately, using the smokeless tobacco products. And just because it's smokeless doesn't mean it's harmless. So this is really important. We can save our patients' lives. So this is something that we really need to do for every patient, and we can save lives. I just want to mention to you that DenMat, who I lecture for, has generously made an offering, an incredible offer, a substantial discount for their Velscope, for the camera, and all of the disposables that you need for covering the Velscope. And if you are interested in this, you can call the rep for DenMat directly at her phone number and place the order. You're not going to see an offer this low for any other group. For some reason they like me and they decided that they would like to do this. Okay, as mentioned earlier on, Steve mentioned that there will be resources at crowncouncil.org, the research papers, the clinicals, the scripts, and a copy of the public service video that the American Dental Association made in 2010. You can burn a disc from that and play it on your reception area and get people interested in doing the right thing. Okay, so I think that's my half hour.
Perfect.
I've enjoyed speaking with everybody.
Thank you, Jim. Before we move on to the verbal skills, maybe you could address one concern that seems to crop up occasionally. The ADA came out with an article in the Journal of American Dental Association several years ago on this particular topic, and there was some confusion about what their conclusions were based on the research of these enhanced oral cancer exam devices. Can you clear that up for us?
Absolutely. There was an article published in 2010 in the Journal of the American Dental Association, and this study was done in India, and they only used the scope on lesions that were visible under the operating light, which kind of doesn't make any sense. So they actually missed a lot of things. It was not routinely used for all exams, and in my opinion, it was a very poorly designed study. Since then, there has been a lot of research and other articles published that have knocked the wind out of the sails on this particular research project. And I encourage everyone to read the newest research. There were a lot of flaws in this particular research project. None of them were actually calibrated on the use of the device. They sort of winged it. So I'm not sure that there really is any validity to that study, Steve.
Got it. So there is now, and like we talked about, we'll have that posted on the Crown Council website of the studies that have been done since then that show the validity of using an enhanced some kind of device to detect oral cancer. So thank you for the background.
You're welcome.
So a big part of having any type of technology in the practice is knowing how to talk about it. And so Pam Peterson, who's our senior practice advisor at the Total Patient Service Institute, and I are going to walk through some suggestions on how to incorporate it, and for those who have already incorporated, some very specific verbal skills we found to be of use to make it work. So Pam, welcome.
Thank you, Steve.
So here's a couple of prerequisites that are essential to making the technology actually work in your practice and being able to use it with your patients. There are many in dentistry who have had the experience of where they brought technology into the office and then it gathers dust over in a corner. And so part of the process here up front is to make a decision. And that decision is a philosophy of care decision, not just a decision to buy a piece of technology, but to decide what is it in your philosophy of care and line that out and explain, especially to the team, the why of introducing the technology into the practice and why it's important and how that fits into your overall philosophy of care. Step number 2 is then to build confidence within the entire team of the technology itself. Watching this webinar and having Dr. Pasternak walk through all of the whys and the science and the examples certainly builds that confidence, so that when patients are approached, that you can communicate with confidence that you're doing the right thing, that you're doing it for the right reason, and it'll be of huge benefit to them. And then finally, consistency is the key. In other words, your patients need to see that you're using it, that you talk about it, that it is mentioned, that you have a consistent program in place where you use the technology. For example, that you do a enhanced oral cancer exam every year. That's part of your protocol, and that they get in the habit of seeing that on a regular annual basis. So those are 3 prerequisites for consideration to build the foundation for incorporating any kind of technology into your practice, but in particular what we're talking about today. Pam, maybe you can talk about when a new patient comes in, or if you're introducing the technology for the first time, what happens at the front desk?
Be happy to. First, make sure that you have patient information on hand, and it's available from any supplier who sells Fellscope, Oral ID, or Visalite. And just like Dr. Pasternak mentioned, DINMAT, who I'm familiar with, is a great resource if you need paperwork to make sure that you have it so that you can review it with your patients. Go ahead, Steve. I'm sorry.
One of the natural laws, you all know I'm a big natural law guy, is in this area, and the importance of having the written information on the technology is that people believe more what they see and hear, more than just what they hear. So if you have anything written or documented that backs up what you're going to tell them, this is also priming. A form of priming, those of you that have been through the Total Immersion course from the TOPS Institute are familiar with that concept, is that it gets them prepared to take further actions. So the written part is very important to have so that they can see it, touch it, feel it, and know that the conversation's coming.
And Steve, I have one more thing to add. As mentioned for the oral cancer exam, Dr. Pasternak mentioned being organized. The same thing with your paperwork. I know that everyone on the call has their new patient paperwork ready and organized when the patient arrives. So if a patient arrives in your practice, make sure that you place the document, the pamphlet on oral cancer screening, on the top. That way it supports consistency. If your patient downloads the paperwork from your website, or if you mail it to them, make sure you ask follow-up questions to ensure that they reviewed the pamphlet or received it.
Excellent. Now, in terms of what is said, Pam, maybe you can walk us through what the person up front would say to the patient as they're checking in, so that there is some mention of this. It's not just another piece of paper they're handed, but there's some mention of it.
All right. You walk in, Steve, you're my new patient. I will stand and greet you and review the new patient paperwork with you. And on the very top will be an oral cancer screening document. And I would hold it up and hand it to you and say, Steve, this is some information on our oral cancer exam that we do once a year for all of our patients for the annual routine exam. You are welcome to read over this now so that you're ahead of the game when Tanya, your hygienist, talks to you about this today.
Excellent. All of these, by the way, the verbal skills that we'll go through will be posted on crowncouncil.org at the conclusion of the webinar. So then moving on, there would obviously, there could possibly be some questions about that. We'll talk about a few of the potential objections and questions that that patients might have, especially if they're existing patients. If the patient now goes to hygiene, then the hygienist would give an overview of what the exam, the entire exam is going to include, and what's going to be included, including the oral cancer exam. So Pam, why don't you share with us the verbal skills there?
Happy to. Well, using orienting comments, and all that means is letting the patient know what to expect, Also, when the patient is seated, you'll take a look and I would say, Steve, I see that you have information given to you up front. Dr. Pasternak strongly recommend that all of our patients do this once a year. Has anyone ever done this for you before?
One of the keys here is the word strongly recommends, or Dr. Pasternak is strongly recommending. Those are key words. For whatever reason, the word recommend carries great weight in terms of the degree to which patients listen and consider anything that is being recommended. So then the question, Pam, tell us a bit about the question. Why do we ask, has anybody ever done this for you before?
Well, most patients have had this done, but they're unaware. There are many practices that go through all of the steps without informing patients of why they are doing it or what they're doing. So patients may have had the fill, felt, and the visual oral cancer oral cancer exam, but unaware of it. And so it's nice to let patients know what to expect, what you're doing, and why you're doing it, so that they know that you're taking care of the total patient and not just the teeth.
You got it. So moving on with that explanation, part of that explanation is to explain that what we do here, we do this for all of our patients when we do their routine exam. In the past, an oral cancer exam was done by just touch, feel, and looking around, but now we're excited because the latest technology shows us any early signs of oral cancer that we would not have been able to detect in the past. So that's the benefit statement to them of early detection. And you could also include the value of early detection, like Dr. Pasternak has outlined, is that the earlier it's detected, the easier it is to treat and prevent a more serious problem. By the way, I always have to explain this for those that may not have been through the total immersion course. You've seen now twice our description of the exam as routine. So that bothers some people, but there is a reason we call it a routine exam instead of a comprehensive exam. Routine means that it's done commonly and as a common practice. And all of us, in terms of buying psychology, are more likely to do things that are common and everyday that everybody does than we are things that might be out of the ordinary. So as you describe this as part of your routine exam, then the message is that everyone is doing this. And that's why we've included, this is what we do for all of our patients when we do their routine exam, meaning everybody's doing this. This is part of our protocol. This is how we try to treat our patients, and all our patients are treated the same. So a couple of highlights there that might help. Those are great psychological triggers. Pam, tell us about this word picture, because I think this helps, especially for women, it helps put this in perspective.
You know, Steve, I feel that male or female will understand this, and it's really important when talking about the oral cancer screening is to make it easy to understand by using word pictures or comparison, so that patients go, okay, yes, I get it. And so if I'm speaking with a male or female, I would just say it's similar to a woman having a mammogram or any type of preventive analysis to help detect things early so that it can be treated successfully. And then you would check in with the patient. How does that sound? Isn't that great? And then I would share with them there's a nominal fee of $39 for the exam. Are you ready to get started today?
So the point here obviously is give them something that they can relate to, that they're very familiar with, like a mammogram. The fee is just a part of the conversation. We don't make it a big deal. We don't even get into the insurance discussion unless they bring it up. So the fact that we're presenting the fee implies that that's something that they'll pay for. And then if they bring up the insurance question, then absolutely we'll say that we will be happy to submit this on their insurance, as Dr. Pasternak has included, that there are not a lot of insurance companies that cover this. We'll be happy to submit it for you, and in case they do, it'll be a nice surprise. So you're going to ask the closing question. Are you ready to get started so you can move things along? And then the hygienist, when the hygienist introduces the patient to the doctor with what you're all familiar with that we call a relationship link. You're going to review everything that's been discussed with the patient, and then also say, Dr. Pasternak, we also talked about the oral cancer exam, and Pam's ready to get started. So just link it all together, and off we go. Pam, any other comments in terms of what happens in the hygiene room before we talk about any objections? And
well, there's two, confidence and consistency, and I know that you targeted that at the very beginning. One is take this information, understand it, and not give patients objections. When we are consistent and we believe in what we're talking about, it's not so much as how much is it going to cost, is insurance going to cover it. If this is our belief that this is a screening and it'll work in conjunction with what we've been doing for years, it's easy to do. And the example that I used for a mammogram, for years before the mammogram was even here, that's all the doctor did was what he or she could see or feel. And so when the screening came on board, not once did my doctor ever mention to me about insurance. She let me figure that part out. She just strongly recommended that this is what I do in conjunction with what she did in her office. And so I would recommend that we adopt that same philosophy when taking care of our patients.
you got it. Thank you. All right, if the patient objects, Pam, if you're the hygienist, I'm the patient, and I say, Pam, is this really necessary?
See, tell me more about your concerns.
Well, it just seems like it's just one more thing to do, and does it really show you that much more? I mean, is it really that important?
So, Steve?
Yes?
So what you're asking is if it's really important to have this done today.
That's right.
All right. If there were a way to detect anything that could be potentially threatening to your health, would you want to know about it today?
Yeah, I mean, I'd want to know about it.
All right. So wouldn't it make sense that we move forward with the oral cancer screening exam so we can give you peace of mind about your oral health while you're here today?
Yeah, it makes sense. Or I might say, well, can you really see that much more than the way you've done it in the past?
We could see a lot more than what we have seen in the past. In the past, we couldn't see anything until it was visible. And when it was visible and we could actually see it, it was at a stage where we could have treated it before it got to that stage where it's more invasive to treat when it gets to the point where I could actually see it and touch it.
Excellent. I'll tell you another word picture that you might use in that situation when people say, can you really see that much more? A great word picture would be to say, Pam, this is the difference between a soldier in Iraq being on night patrol and just having their regular eyesight versus having night vision goggles to really see what's out there that they can't see with just their naked eye. So these are like our night vision goggles that help us see what's really there that is very, very difficult to see early on. Does that make sense?
Yes, that was an excellent word picture. I wish that were mine.
Well, it is now.
Okay, got it. I like it.
I'll tell you, one of the keys to this, just as a reminder, is that when we get a little pushback, and you'll notice what Pam did here, when we get pushback, our reaction is to tell. Our basic human reaction is to start giving an explanation and start trying to talk them into what we want them to do. And that's exactly the opposite of what needs to happen. The first thing that Pam did when I raised the objection is she asked me a question. She asked me, tell me a little bit more about your concern. She wants to find out exactly what it is that I'm concerned about, and then she answered my objection with a question. Instead of saying, that we can find things out a lot earlier on, and it's early detection, and that really, that'll save your life potentially, tell. Instead of doing that, she just asked me a simple question, Steve. If there were a way to detect anything that could potentially be life-threatening or threatening to your health, would you want to know about it today? That's a very simple question, and now I'm engaged, and I have to answer the question. So as a reminder, questions are the answer, not the answer. The answer is not the answer. The question is the answer. All right, so if the patient declines, if they say, you know, I get it, I understand, I'm just not going to do it today. So then the response might be, you know, Pam, we certainly respect your wishes, and just so that we're all on the same page, if you could read and sign this so that we both have a record that we discussed the oral cancer exam and they're choosing not to go forward at this time. So you're going to give them the informed consent and the decline form so that you have that as part of their record. Then you're going to continue by saying, as we discussed earlier, this is part of our routine exam, so the next time around, we'll mention this again so that you're always in a position to make your own decision. Is that okay with you? So, in other words, because you are going to mention it again when it's time for their routine exam, and that you'll keep mentioning it to them so that they can always make the decision themselves. What we find is, presented in the right way, that over time with enough repetition, that not the majority, not even the vast majority, but 90% of your patients will go along with this as they see that it's become your standard of care. With that, we're back to the front. So at the end of the appointment, let's say it was the end of the hygiene appointment, Pam, as the hygienist, would walk me up front and to the appointment coordinator would say?
I would say, Steve had a great visit today. We did an oral cancer exam and we're glad the results were negative. We did everything as planned, so he is ready to schedule his next visit in 6 months so we can stay on track and keep getting the results for him. Steve, is there anything I've missed or we need to discuss before Tanya gets you scheduled for your next visit?
Nope, I think we're set. I appreciate your help. So there you go, and that's just the final piece of it to get it all linked together and make sure that everybody is on the same page. So with that, those are a couple of suggestions in terms of verbal skills. Again, all of those will be posted at crowncouncil.org here later this afternoon, along with a recording of this webinar and all of the slides that you've seen today. Had a couple of suggestions or questions about that. Everything that you've seen today will be posted on crowncouncil.org. So here's the challenge to you to wrap up today is, regardless of what your protocol has been in the past, if you already have some type of enhanced oral cancer exam or technology in your office, the challenge is to sit down with the team, have a team meeting to update and review how consistent are you being, has it been totally integrated into your philosophy of care, and review the verbal skills and make sure that you're doing everything you can to make this a part of how you practice dentistry. If you don't have any technology in your practice, now might be the time to take a look at what the options are, revisit your philosophy of care, and make some decisions to enhance what you're doing for the good of your patients. And we all know what's good for the patient is usually what's good for the practice. Dr. Pasternak, thanks again for being with us today and sharing with us the technology and the science. Appreciate the update. And Pam, thank you for your verbal skills help. And thanks to all of you in the Crown Council for your participation today. Hope you've gained some things that will help you provide better service to your patients and help you as you work to grow your practice. Thanks for being with us today. Look forward to having you with us for our next Crown Council webinar coming up. Have a super day. Thanks so much.